Dr. Silverstein. Thank you, Steve. One correction, though. I was involved in conducting the first workshop on dental sealants, where we developed the guidelines for sealant use in Albany, New York, with Dr. Mark Siegel from Ohio. So the Seal America project was Dr. Siegel and Dr. Larry Hill in Ohio. So with that, I want to thank you for joining this webinar. I wanted to be live. I wanted to show my face. And we tested this webinar technology 3 times. And this morning it was working very nice. At 12 o'clock, suddenly my computer froze. So I'm using my cell phone to join this video. So at the last project directors meeting, you told us that you needed more information on programs, and also you needed more information about how to develop sustainability plan for your programs. So we came up with a great plan. So we thought we'll launch a series of webinars. We'll organize a session at the National Oral Health Conference as a pre-meeting session. We wanted to focus on developing a sustainable local oral health program. And we worked closely with Dr. Bahar Amanzadeh and developed a wonderful agenda. And also we wanted to give you learning and sharing opportunity at the National Oral Health Conference meeting. Well, our well-laid plan didn't work out. So times have changed. We are going through this pandemic, and we are going to get over it, and we'll be getting back to business soon. And so we thought, what is the best way to keep the distance and at the same time connected socially? So we thought we will launch this webinar series as well as the American Academy of Community Dental Program virtual meeting. So that meeting, don't cancel that meeting, because don't cancel the registration. We will still going to have that meeting, originally scheduled for April 5th meeting. So we are planning to launch it on April 6th, Monday 9 to 11 on a virtual platform. So it will be a virtual meeting, and hopefully over a period of 6 weeks to 2 months, we will have a series of webinars, and we will cover that topic. So you will get the continuing education credit if you're registered. So please don't cancel that one. So today's topic is School Dental Sealant Program, and that's recommended by the U.S. Community Preventive Services Task Force. And they base their decision on effectiveness and cost saving. So if implemented in target schools, one estimate was that it saves about $300 million every year. But only one state, South Carolina, has made significant progress. I think they cover something like 40% of all targeted schools. But in most states, it's very difficult to cover all targeted schools. So today, what I'll do is I'm going to focus on what are the resources, what are the considerations needed for implementing the school-based sealant program. So as a background, I would like to say that, I was in New York for over 35 years. New York State implemented fluoridation in 1945. By 1955, they had expanded the program to cover many large cities. By 1965, researchers in New York started noticing major decline in caries in children. It's not only the decline in caries, but the distribution of caries also shifted from rich children to poor children during this time. They also noticed that within the mouth, most of the cavities were what we call pits and fissures. These are some of the defects on tooth. That's where they were seeing, and mostly on molars, not on front teeth. And another observation was the progression of cavities also slowed during that time. So they started thinking about how to further reduce caries, and New York State funded researchers in Rochester to test these plastic coatings on teeth, and also they tested they compared the effectiveness of sealants placed by dentists versus placed by hygienists, and they found out it was equally effective. So by 1990, New York State had all the policies in place to promote sealants, and one of them was a series of demonstration programs that increased the prevalence of sealants. So we found out when I came here that the prevalence of sealants in California was low. The best strategy is to implement school-based sealant program. So we met with different partners to get input for our designing school sealant program in California. And the recommendation was that we should provide funding for equipment to local health departments and other providers. So we are creating a grant program for local health programs, and they can apply for this grant, and it will take, I would say, a couple of months to release the request for application. And all this is based on the availability of funding. So we don't know what's going to happen now with this pandemic. So, but hopefully we'll have the funding and you'll be able to apply for this. So with that background, I would like to cover some of the key topic areas. Next slide, please, Katie. Okay, some of these topics that we wanted to cover is mainly to give you resources, because when you are applying for a grant, you have to approach your manager, supervisor, and they're going to ask you a lot of questions. And you have to get their approval to apply for this grant opportunity. So you have to present some facts, figures, and this webinar is designed to assist you to achieve that. And so this is not about clinical procedures. So if you are looking for guidance on how to apply sealants, what is the best sealant material, how should I etch the molar, how long to cure the sealant, this is not the webinar. So this webinar is mostly focused on local oral health programs and how to increase the prevalence of sealants and reduce tooth decay in their jurisdiction. Next slide, please.
Great. And
so what do we want to achieve in California? So by 2025, we want to reduce tooth decay and untreated tooth decay. So that's the result that we are trying to achieve. And we have created a technical package of interrelated interventions to achieve that one. So in this diagram you see, our goal is to reduce cavities and create a generation of cavity-free children. And from my left is community water fluoridation. This has the strongest evidence, and this has the capacity to reach the largest population. So effectiveness is one. The other one consideration is the reach. We can have the most effective intervention. If it doesn't reach the population, we won't see improvement in population health. The next one is community clinical linkage and school-based program. School-linked program is a good example, and I'm going to get into a little bit detail later on. And the other two interventions, kindergarten oral health assessment, we have evidence from San Francisco how it can be used to improve population health. And dental visit is something that it's a leading health indicator in Healthy People 2020. and the last one is oral health literacy. So among all these things, oral health literacy has the weakest evidence, and that is the capacity to obtain information, use it, and make improvement and make decisions to improve health. So the way we want to measure it,
Dr. Kumar, excuse me, we have some quizzes after certain slides. I can't remember.
Okay.
Katie, do you remember?
Yes.
Yeah, we have a slide on. We have a poll for after slide 1. Do you want to do that one? Try it?
Yes, please.
Yeah.
All right, so I'm going to go ahead and launch the poll, everyone. And for those on the phone, the poll is, how many of you are looking into establishing a school sealant program and then it's asking what year. So 2020 to 2021 school year or 2021, 2022 school year. And again, for those on the phone, the question is, how many of you are looking into establishing a school sealant program in this year or the next school year?
So Katie, the submit button is not highlighted. So I cannot hit that submit button.
Oh, okay. Well, we can see it's slowing down a little bit. So I'm going to go ahead and end the poll, and then I'm going to share the results with everyone.
Okay. You want me to proceed with the presentation or wait?
Can you see the results on your screen? So it looks like 60% are looking to establish a school sealant program this year in 2020, 2021.
Oh, very good.
Yeah, so I'll stop sharing and we'll keep going.
Okay.
And then Dr. Kumar, do we want to take some questions now or do we want to wait for another slide or two?
Another slide or two. I'm going to cover some key slides.
Okay, thank you.
Okay.
Okay, thank you.
All right. Yeah, I don't see the results. Some of the comments are that they don't see the results. I don't see the results also. Okay. So I'll continue with the presentation. So I'm looking at this slide here with multiple interventions, and that's our technical package. And the way we want to measure our performance is we want to see how much are we doing, how well are we doing, and is this making children healthier? So that's by looking at the reduction in tooth decay and untreated tooth decay. So I mentioned about community clinical linkage. These are connections between community and clinical sectors to improve population health. So when clinical and community sectors work synergistically, they can improve care and support patients better than either of these sectors could do alone. So we include this as helping to ensure people who have tooth decay are at high risk for tooth decay, and we want to ensure access to the resources they need to prevent and get treatment services. Enhance the collaboration among the public health, healthcare, and community and non-healthcare sectors could produce better prevention and treatment outcomes. So what we want to do here is to bring together schools, that is the education sector, public health sector, and the clinical sector, and to achieve two things. One is to increase clinical preventive services, and the second one is to change behavior so we can promote healthy behavior. So these are in your grant deliverables. So can you go to the next one? So school-based programs are not new to California. There are many school-based programs have hired from many local oral health programs. So I have a list here. Somehow Sonoma doesn't show up on this particular slide. So I updated it. So I'm going to wait. Okay, is there a poll after this one?
Yes, there is.
Okay, good.
Do you want me to go ahead and do the poll?
Yes.
Okay. All right, launching. So please select which one applies. So I know of a school-based sealant program that I can consult with, or I would like to visit a program to learn more, or I am not interested. And you guys are voting. It looks about 75%, 3/4 of you would like to visit a program to learn more. I'm gonna go ahead and end the poll, and I'm gonna share the results and see if it works this time. Can you guys see the results?
Yes, I can see the result. Okay, so there is a lot of interest among local oral health programs to visit a program. So we'll make sure, Katie, we'll make sure that that information is made available to participants.
Wonderful, and it looks like from the chat box, Dr. Pendekar from San Mateo County is piloting a Sealant program.
Okay. So the next slide. All right. So this is a graph that CDC produced as part of CDC Vital Signs. This was produced in 2016, comparing 2 national surveys among 7 to 11-year-old children looking at first molars and comparing tooth decay rates in children with sealants and without sealants and by income status. So when we talk about low-income children in this survey, Susan Griffin and her colleagues looked at those children with 185% or below federal poverty level. That's the definition of low-income children used in the survey. So you can see the difference between the highest and the lowest. So the lowest rate of tooth decay, that's 19 molars affected out of 100 children, or about 5% of all molars. That's among higher income with sealants. And if you look at lower income children without sealants, it's 4 times higher. So when we have the data from the 3rd grade survey children in California, we will be able to see a picture of cavity rates in California. So the next slide. So the prevalence increased in most states over, I'm sure prevalence has also increased in California, but what you see here is the decrease in disparities. And so there are many factors for this one: school-based program and Medicaid insurance, Medicaid coverage. Both of them made increased this prevalence of sealants among low-income children. So the next one, this is to give you some, the next slide is about dental sealants, and this is the procedure. So as I said earlier, this is not about clinical procedure, but I just want you to go, I want to go over the process involved. So fluoride works best on the sides of the teeth, relatively speaking. And most of the cavities are found on the biting surfaces and what we call in some of the defect areas on the tooth, and some are on the cheek side, some are on the tongue side, but most of the cavities occur on the first molar and the biting surface. So that's the focus of most of the school-based sealant programs. So we start with a clean teeth. So by that I mean you have to make it clean because generally those teeth are not seen. So that's number 1. So we clean the teeth first, and that the picture shows here is a clean tooth. We begin with that, and then we use some acid to etch the surface, and the next we again spray water and dry it, and that's basically to get a clean surface. And you know, there are different materials that we use. Some when we use resin sealants, for example, it has to be absolutely dry. And then the next thing is we put a coating of sealants on it. There are different ways we coat it. There are different materials. The flow is different, so I don't want to get into the details. The next step is here, they are using a light to harden the sealant. And there are many different kinds of curing lights. Some are very fast, some are slow. There are lights that can cure in 5 seconds, 10 seconds, but you have to check with your manufacturers to make sure what works in your situation. There are sealants that can be cured without the light as well. So, and when it is finally done, it should look like this. All the pits and fissures are covered with a plastic coating. So before, there is a picture on the side showing before and after. So that's the basis. So fluoride, sugar, and sealant. So if we, if we increase fluoride use, decrease sugar, and put sealants, it should give you a very good protection against tooth decay. So the next slide is about what is needed if you want to launch a school-based sealant program. So you have to choose equipment very carefully when it comes to here, because when you approach salespeople, they want to sell a lot of things. So then this is where you have to consult with somebody who has used it before to purchase the right set of equipment. So on the top, I have a list of portable dental equipment. For school-based sealant program, all you need is a set of equipment to deliver sealants. We don't need mobile vans. We don't need fixed facilities. So these are very expensive, designed for primary care, and we don't encourage anybody purchasing mobile vans or setting up fixed facility to deliver sealants. So the next slide is about the background. I'm going to go through some time period. In 1983, the National Institute of Health conducted a consensus conference, and that was because two major reports came out in the 80s. One from a demonstration program that included about 20,000 children across 10. California was one of the states that participated in that demonstration program, supported by it's called the National Preventive Dentistry Demonstration Program. And basically that said, of all the interventions implemented in a school, education, toothbrushing, topical fluoride, sealant, classroom education, and then fluoridation, only two things they said worked. One was sealant, the other one was water fluoridation. And there was also a big national survey of children, about 40,000 children, which showed for the first time substantial decline in tooth decay and this change in the distribution of tooth decay within the mouth. So that led to this conference where they encouraged the use of sealants in educational institutions to educate and train dentists, dental hygienists to apply sealants, encouraged local health departments and state health departments to set up demonstration programs to demonstrate the efficacy and effectiveness and cost savings, and then they encouraged insurance company to cover the benefit. So that was the time New York State started demonstration. I had the opportunity to design the demonstration program. We funded, we provided grant in those days, $50,000 to a county health department to implement sealant program. And we funded initially 10, and then we expanded it later. And in 1995, and many states did that. Ohio was another state that had a statewide sealant program. So Dr. Mark Siegel was the state dental director in Ohio, and we got together, we said, let's see the progress over the last 10 years. And we conducted the workshop, it's published now in the Journal of Public Health Dentistry, a whole issue dedicated to the guidelines for sealant use. And in Healthy People 2000 included sealant as one of the measures. And then in the Title V Maternal and Child Health Block Grant that provides funding to state health departments. It included a very specific performance measure, and that was to increase the prevalence of sealants among third grade children to about 50%. And then in 2003, Community Preventive Services Task Force came out with a report. They looked at all the available community preventive services. They recommended two. One was water fluoridation, the other one was sealant. And then in 2009, there was an expert panel to look at some of the issues that dentists had raised about the sealant. One was progression of caries underneath sealant. Some dentists said they were concerned that cavities were progressing after the sealant placement. And the other thing was about the use of X-rays in school-based sealant programs. So we don't recommend the use of X-rays. So if you look at those guidance documents that was published by the Journal of American Dental Association, you will see those recommendations that it is safe to provide sealants even on incipiently carious lesions as long as the sealant is intact and there is no need for X-rays in school-based programs. And lastly, the 2003 guidance document was updated in 2013, and again, the recommendation is to promote the use of sealants. And the next slide is about how to build interventions in schools. Katie, can you advance the slide? Okay. So this is, I've used this diagram since, I think, 1990s. Basically, I took all the interventions, key interventions in schools. I put them in different categories, and there are some schools that need primary care services. These are fixed virtual dental homes and mobile van models. And this is primary care. I want to distinguish primary care from school-based sealant program. So what is primary care services? That's ongoing, continuous, comprehensive services provided in schools. So you are the primary care provider if you are in a school with a fixed facility or a virtual dental home or a mobile van. Whereas school-based sealant is a public health program, and it's one-time, long-lasting prevention. So you have to think this like the adult immunization program, like flu shots in senior centers and some of those settings. It's one time, and the intervention is long-lasting. So that's the difference. So between school sealant program versus a primary care program. A school-based health center is another example of a primary care program. And the next one is school-linked program. CDC, this is a community clinical linkage model. And in 2003, Community Preventive Services Task Force included this in their systematic review. But in 2013, there were not that many school-linked programs with data to evaluate. So we need to build strong evidence. And I'm a big fan of school-linked programs. This is to establish a dental home, screening, counseling, referral, and care coordination, and focused on selected grades. So the weak part in the school-linked program is the linkage aspect. So we don't have a good system where we can refer children, link them to a source and track the referral and make sure the referral is closed. So we are working on that one now. So we want to identify some good softwares where you can refer, and the dental offices and dental providers can pick up the referral, and they'll send you a note when the referral is closed. And so you know of 100 children referred, how many of them actually went, visited, and received dental care. So that's what we are working on. So you can, so the next slide, we'll talk about that. And the last one is healthy environment policy. So I have arrows on the side. One is, as you move up the pyramid, you need the intensity of the services will increase, so does the cost. And what happens when you go up the ladder? Your reach becomes less and less. So if there are, like 1,000 children, and if you want to provide primary care services to all 1,000 children, that may be possible. But if it is a county with 30,000 children, it will be very, very hard to do primary care or implement primary care services. So it depends on so you have to match the schools with the intensity and that is matched to the need. So the next slide. So why promote school-based program or a school-linked program as a public health program, not as a primary care program? So, and that is, I have certain criteria that I use. The first one is the problem has to be widespread. And part of that is you have to look at disparities. If the disparities are profound, or if the problem is widespread, that is one criterion for selecting a public health program. The second one is this problem preventable? So tooth decay is generally widespread. I hear that 70% of third grade children will have already experienced tooth decay, and we see big disparities between low income and high income children, low income schools and high income schools that fits these, and the problem is preventable. So we know there are interventions available. And the third one is, this is key. So if an intervention is available, and we want to know whether the people who need the most, are they getting it? So in other words, there is a way to prevent the disease, and it's not available to those who actually need it. And Sealant fits in that category. If you look at the prevalence of Sealants, that is always, among low-income children, if it is low, then you have to select a public health program. So that's why there are Healthy People 2030 objectives that will be coming up, and is slightly different from 2030 objective. And the proposed objective is to increase the proportion of children and adolescents aged 3 to 19 who have received dental sealants on one or more of their primary or permanent molar teeth. I am not a big fan of sealing primary teeth. I'm a big fan of sealing permanent teeth. I don't want to get into the details why, but if you contact me, I can explain to you why. The next one, the other thing is, we have a very specific objective in our California oral health plan. By 2025, increase the prevalent sealants from 27 to 33%. So we will have much better data. We have completed the survey of third grade children in California. We are in the process of linking the data to the Department of Education data. We will be analyzing that data. Hopefully, in another 4 or 5 months, we'll have the results of that one. And we will make the adjustment to the baseline as well as. Usually, we want to see an increase of about 10 percentage point over this period. So the next slide, as I said, the 2003 community preventive services included both school-based and school-linked program as effective in reducing tooth decay. So there is a difference between these two approaches. So the first one is, the school-based program is ideal where you don't have a lot of providers. There are a lot of issues related to access to care, so you can at least protect first molars from getting tooth decay. So that's one of the considerations in selecting school-based program. If there is capacity in the community, then there is, you may want to look at school-linked programs. So the idea of identifying children in school who need sealants and treatment services and linking them to a source of dental care becomes easier in a community where there is capacity, where there are dental practitioners in the community. The second one is the availability of resources. So this is school-based programs are very resource intensive. So you, as compared to school-linked program. So you have to have good support, you need a lot of space, and you need trained people, and also you know, you have to generate enough consent in order to make it work. So you need a lot of support from schools. So my recommendation is the support from school is very key. And one way you can find out whether they are really supporting school-based program or not is to look at the space they give you. If they give you a closet, that's not a school you want to go into. If they give you a nice space, like a nurse's room or a separate classroom, or even a gym area where they say, you know, we can partition this place to set up a temporary clinical facility, you want to get into those schools. So the first thing is, you know, if the support from schools is key for establishing a school-based program. And with school-linked program, that's not the case. And, you know, it's very doable even in large counties because you can screen a lot of children in a day. You can screen as many as 100, 150 children. So the screening part is easy in a school-linked program. The hardest part is making sure that the linkage is established. So if you screen children and if you don't link children to a source of dental care, it is basically worthless. And one key consideration is the consent, the consent rate. So what we have seen across the nation is the consent rate when it comes to, say, obtaining consent for the application of sealant or fluoride, it drops. And if you get 30%, 40%, and especially those who actually need the services who are not participating in the program, then it's not good. So it's not going to help us achieve our goal. So with a school-linked program, you can use a passive consent. And that way, at least you can screen all children and you can identify those and you can persuade parents to go and seek dental care. So with insurance available to 100% of the population of children in California, we think both these models are doable. So that's something that you have to make a determination whether you want to go the school-based route, school-linked route, or you want to have both of them in your approach in order to accomplish the objectives. So we have said you can use your funding, the current grant funding, for both school-linked program and school sealant program. But we want you to generate the revenue if you're providing direct clinical services. Do we have a slide? Do we have a poll now?
We do.
Katie?
Yep, we have a poll. Let me go ahead and I'll launch it.
Okay.
Okay, I'm launching the poll. For those on the phone, the question is, which model of a school sealant program are you considering to establish? School-based or school-linked?
Katie, the poll didn't come up.
Didn't come up? Okay, that's why it's not. Let me go ahead and end it. Let me try it again. One moment. Okay, can you see it?
I don't see it.
Okay, sorry everyone, it's not working for some reason. We'll try the next, actually here it goes. I see someone used it.
Okay.
Is it working? Let me check the chat box. No, same here, shoot. I don't see
Yeah.
the poll.
Okay.
Sorry guys, I'll go ahead and end it.
All right. You can go to the next slide. Okay. So we have all the policies in place in California to promote sealant programs. The first one, the Children's Dental Disease Prevention Program, it's in the law, and it includes sealants. So the Dental Practice Act in California is very liberal compared to many of the states. In some states, you have to have a dentist first examine the child, certify which teeth to be sealed and all. So in California, actually, it allows a hygienist to go to a school and apply sealants. And the policies in the Medicaid program permits dental hygienists and registered dental hygiene practitioners, dental hygienists, and registered dental assistants to apply sealants, but there are only certain practitioners who are enrolled in the Medicaid program can bill. We can help you with giving you more details about who can participate, who can enroll, who can bill, under what circumstances they can bill, all those details in a separate webinar or through written instructions. So FQHCs can go to schools and provide services. So in order for FQHCs to go and set up, they have to set up interim clinics. And there is a process for that. And many departments are involved in this one. The Medicaid program is, CDPH is involved. And most importantly, they have to get approval from HRSA in order to do this. So there is a whole process involved. And it takes some time to establish interim clinics in schools. And then, of course, county clinics can also do this one. So there are, in my opinion, most of the policies are in place to promote sealant programs in California. So the next slide is about implementation guidelines. Okay. We recommend targeting school sealant programs to only those low-income schools. And also targeting certain grades, like second and third grade, sixth and seventh. In second grade, most of the first molars are erupted. You can apply sealants, and then you have to go back and check if the sealant is intact, and you can do it in third grade. And if there are some new children in third grade, and if there are new teeth, you can apply sealants. And again, you can do the same thing on second molars in sixth and seventh grade. So I have some experience with targeting. When we established the sealant program in New York, we wanted to show that we can save money. In order to, this is one of the issues with sealants. Sealant is expensive when you compare it to some of the other so we wanted to make sure we can save money with this, because the cost of preventing, if it on a population level, is more than the cost of treatment, then you had to think about it. So with sealant, that was one of the issues. So we wanted to target these programs to low-income schools and in certain grades, and then we wanted to select children who are at high risk in school for tooth decay using some subjective criteria, and then we wanted to select only those first molars with deep pits and fissures that are more susceptible to cavities. So We did this over a period of 5 years. I get, in some 12 counties, we gathered the data over a period of 5 years, analyzed. Well, what we found out was targeting, even with a lot of training, was difficult. It was easier to target schools. It was easier to target grades. But when it comes to selecting children and selecting teeth, it was very difficult. So we gave up after trying that approach. So now the recommendation is target low-income schools, target certain grades. And then you have to, in your implementation, you should consider how you're going to build community support. As I said, if you don't have support from schools, it's not going to work. And then obtaining assurances from schools, that is key, and from providers. And then selecting equipment. And then you should give consideration to good infection control. And this is especially important now because our infection control practices are mainly for bloodborne pathogen, not for airborne pathogen. So this COVID-19 has changed it completely. So I don't know how this is going to come out at the end of the day. So this is whether we have to change the whole practice, or once this pandemic gets over, everybody's immunized, and there may not be a need to consider that. But right now, our infection control is for bloodborne pathogen only. It's very difficult. That's why, we ask those with tuberculosis and those kinds of conditions to come back later after they're treated. And waste management is also an issue in schools, so you have to think about that. Maximizing response, as I said, the consent is a big issue, and then sustainability of the program. So now I want to go to the next slide. Okay. There may be some questions. I want to see if there are any questions, Katie. Maybe I can take some questions now.
Great. Yeah, there's the chat box has been pretty busy. So
I see.
a lot of back and forth, which is, we really want to make this engaging for everyone. So at the beginning, if we can go back just a little bit to the RFA, I think there was a question about if this was going to be open to FQHCs.
No. This is not a competitive, because if you go through the competitive route, it will take us about 2 years to push the funds out. So that's the reason why we are not going to go through that route. So it is a lot easier to push the money out if we go through existing contractors. And those are our local oral health programs.
Dr. Kumar, can the local oral health programs loan equipment to a FQHC?
That's what I was going to talk about in the next few slides.
Okay.
All right, and then there was a question about fluoridation. So this may, there's a lot of back and forth about some of the studies that have come out about fluoridation and toxicity. So maybe that's a question we can either have at the very end of the webinar, or even we have a separate webinar altogether.
Yeah, end of the webinar. Yes. Any more questions?
It looks like we have there was another question on if we were going to be addressing more of the details of school programs about FERPA or like HIPAA, positive consent forms, opt-out consent.
Okay, so that's a separate webinar.
All right, wonderful. And my friend who's a school teacher just got in, so this is good timing for this. we have one more. I would like more funding, information on funding.
So about funding, we cannot, talk about the details about funding in a webinar without releasing the RFA. So look out for that RFA. When we release it, then you will have that information, and then we'll follow up with a webinar. Okay?
And then just one more question. It's a little bit on the clinical side. But school-based programs, is a diagonal dent laser, is that required for?
I am not going to answer questions if it's related to clinical issues today.
Okay, so we'll wait on that. Okay, then we're caught up on the chat box. Thank you.
So, so this whole webinar is about, to prepare for this forthcoming grant application, right? Forthcoming grant opportunity. So that's why we want to talk about the costs. So are you interested in applying for this grant? It depends on developing some plans, including business plan, and you should know about how, what's going to cost. So the best paper about that is by Susan Griffin. She's a health economist with CDC, and she has done a lot of work on dental sealants. And she has a paper, I think, that was included as part of this webinar, and it's about estimating the cost of school sealant programs. So according to her, in this paper, she says the total annual costs are about $134,000 based on based on the 2016 dollars, and per child it was about $66. So this was a mature program. They looked at several programs, and all these programs, but they were mature. In other words, they were already in place about 4 or 5 years, and they had figured it out, all the details, and they were very efficient in operating the program. And so the main cost here was the labor cost. It's about 80 to 85% of it is labor cost. So in this particular estimate, the way they used the equipment cost was they amortized over a period of time. So every year it was only a small part. And I think I have a slide. So the labor is the most important cost when you're looking at sealant programs. So the next slide will show you a little bit more details about, about durable items. So these are some of the categories. You need supplies, and you need equipment, you need labor, and part of the administrative expenses are also labor. So you can see the labor here refers to clinicians who are providing services. And the administrative services here is about care coordination, doing the paperwork, and those kinds of activities. And the total is $135,000. So one of the things in this cost that Dr. Bahar Amanzadeh pointed out to me was that the care coordination part was not included. So that, you should think about that, because there is no point if you just provide this one-time clinical service and not link them to a primary care service for ongoing prevention and treatment services. So that's why, you should have a very good clinical linkage program as part of the school-based program as well. So the next slide, okay. So Dr. Griffin's paper used some assumptions. So the first one was four-handed technique. So I think this is very critical. Four-handed means there are two people working with a hygienist and a dental assistant, or a dental assistant and and another assistant under the supervision of a hygienist, some kind of setting like that. And spending 6 hours per day in school, providing about 3,400 fluoride applications at 1 minute per child, and serving 58 schools. That means they were moving constantly over 100 days. That's about 20 children per day. That's and then providing about 3,390 screenings, and then 2,000 children received about 6,000 sealants. And so they also perform some care coordination. This is as I said earlier, this is a mature program. So it will take at least 3 years for a new program to reach this capacity. So you have to take this into consideration. So what I think, the next slide. So you can make some assumptions about the revenue projection as well. So in year 1 and year 2, you're thinking about 750 children or so. And Dr. Griffin assumed 20 children per day. I made this assumption of 10 children per day. And that this is more reasonable than to a mature program. And I assume that one RDHAP will be working with one dental assistant. And if there are about 750 children and 10 children per day, you need about 75 clinical days. And you need some days like 25 preparatory days, distributing consent, gathering it. You need some time for billing, all those things. So this assumes that you can bill for fluoride application, tooth prophylaxis, and then applying about 1,500 sealants. So this is, instead of 3 sealants, I assumed about 2 sealants. So this is the current schedule, okay? So based on that, this is about 62,000 you can generate if you see 750 children. So my recommendation is to start small in year 1. So generating this revenue depends on a lot of factors. So you have to, you're assuming that you can collect insurance information for all the 750 children. And that is a huge challenge. And then it takes some time to build trust. So nobody is going to give health insurance information if they get a consent form in their mail, right? So it's going to take some time to build the trust. So that's why it takes some time to ramp it up. So it's 62,000 for 100 days. That is about $620 per day. This is in my opinion, a realistic figure, but it assumes that you're collecting insurance data on 100% of the children. Okay. So this is. I see a lot of questions from Dr. Shakalpi Pendurkar. I'm going to stop here and take some of those questions.
All right, so I'm bringing up the chat box here.
What's that?
I'm just bringing up the chat box for everyone here.
Okay.
So one question is, is this a factor of the shortage of RDHAPs?
No. As I said, if you're selecting a school-based program, the first thing is there should be the availability of trained personnel is a key consideration if you're using a school-based sealant approach. So if there are shortages, then you won't be able to implement school-based sealant program.
Yeah, and just looking maybe at the difference geographically between more urban settings and more rural settings. There's a question about if you're in a rural setting, on some of the distances, you can travel up to 90 minutes between schools.
That means you'll be less productive. That means you can anticipate less income. So you can use this to make those adjustments. Instead of 10 children per day, you can say, I'll be able to see only 5 children a day. And you may say, okay, it will take me, instead of 75 clinical days, it will take me 100 days. So you can figure in all those things to get some ideas about how much money you can generate by billing for these services. And this assumes that this is a fee-for-service program, not an FQHC. So that is a different model altogether.
Great, thank you. I think that answers one of the questions about looking at a business plan model of who is billing and the mechanism for how they are billing.
Okay. So as I said, we can talk about the actual billing. Do I have I think I have a poll about, whether your county is set up to bill and generate revenue or not. That's
You do.
one of the
Want to test it? Are you ready for that one?
Yep.
Okay. I'm going to go ahead and launch the poll and see if it works.
Yeah.
Anything happening on your ends?
Yep, I can see the poll.
Great. For those on the phone, the poll is, my county can bill for clinical services and generate revenue. Yes, no, or don't know. Oh, right now, it's actually a three-way tie. I'm going to go ahead and end the poll here. It looks like the numbers are adjusting a little bit.
Uh-huh.
And I'll share the results.
Okay, so about 29% said yes, 29% said no, another 40% no, don't know. Okay, something that you want to check and see if you can bill for these services and generate revenue to support the direct services.
And then there was a second part of that question. Would you like to do the second part of the question?
Yep. Mm-hmm.
Okay, so I'm going to go ahead and launch. Just give it a few seconds here. The second question is, my county can bill for non-clinical services, such as education, outreach, and case management. And the poll is just loading up here. Yeah, sorry, it might not be, this one might not be working.
Okay.
All right, I'll go ahead and end the poll. Sorry, guys.
All right.
But Dr. Kumar, there was a question in the chat box about, I'm gonna try to relaunch this. As a dentist, I guess one of the questions is the child's primary dentist gonna be okay if their patient is getting sealants outside of their dental office?
Okay, I have a slide about that.
Perfect, we'll come back to that. And it looks like the poll is working now for non-clinical services, for education, outreach, and case management. So I'm gonna go ahead and end it and share the results.
I see. It's very interesting. 0%. Okay. So you may want to talk to your MCAH program and see whether they are billing for non-clinical services. Okay, we'll go to the next one. How am I doing with time, Katie?
Time, we're at 1:11. So we have about 20 minutes left.
Okay. So I'm going to go through quickly several slides here. The first one is the role of governmental public health. So your role, as we said, you cannot use our money for paying direct clinical services because we want you to tap into insurance plans. Every child in California should have some kind of an insurance product, or most of them. And your role, and if they don't have insurance, your role is to make sure that they have insurance coverage and use that to generate the revenue to support direct clinical services. And so what, if you cannot use the money for direct clinical services, how can you support a school-based program? So number one, you can target school-based Sealant programs to areas of greatest. So in other words, you identify the schools, you identify the number of schools and children, and so make sure all the policies to deliver school-based Sealant programs are in place. And if there are barriers, you identify and tell us. And the next thing is you help to connect schools to providers. And if there are clinics, and if your health Department of Healthcare Services is running clinics, so your role is to connect them to providers, to clinics. That's the role we would like you to see. We would like you to play. So the next slide is about the model. So we want to call this a public-private partnership model. So your role is to develop a program plan and a business plan to convince your partners that this is possible in a school. You may want to consult an expert who can provide some guidance, and then partner with a provider. So if you don't have a provider in your community or providers in your community, you won't be able to implement a program in school. So there should be somebody who is willing to go to a school and take the equipment and provide these services. And you can assist these providers in enrolling in the medical dental program, because if you're targeting these programs to low-income schools, a large majority of children will have Medicaid, and they should be able to bill Medicaid and generate the revenue. So you can identify those kinds of schools and grades, convince the schools to establish a program. So this is bringing together different sectors. So you're bringing together the education sector, you're bringing together the clinical sector, and you're facilitating a program. So with our grant program, you'll be able to apply for equipment and some startup supplies, and you can recruit FQHCs, private practitioners, to go into schools and provide those services, and they have to bill and generate the revenue to support the program. But you want to make sure you have the assurances from them to establish a high-quality program, and you have to obtain data, monitor quality, and evaluate the progress. So that's the role we see you playing. So in other words, you can apply for a grant, get the equipment, give it to private practitioners or FQHCs or community clinics, so they can provide the direct clinical services. And if you can build, then you can hire, with the revenue that you are going to generate, you can support clinical staff. So you cannot use Prop 56 money to pay for somebody to go and apply fluoride and sealant, okay? So you need some templates in order to do this. The next slide. So we will work with the UCSF Technical Assistance Center about, samples and examples, like memorandum of understanding with schools and providers, and provider assurances, protocol for infection control, waste management, even clinical protocols. And I'll show you some resources, promotional materials, consent forms, and dental records, referral forms, tracking referrals, quality improvement methods, and evaluation questions. So we will have examples and samples for all these different things. So I'm going to go through a little bit faster now. The next one, so in New York, the state health department actually authorizes. So anybody who is going to school, they have to apply to the health department for permission. So we, as part of that in New York, we developed these assurances. I'm just showing you an example of an assurance and what, so similar assurances, when you contract with somebody, when you're giving equipment for them to take it to a school and provide, and you're facilitating all this, you want to know that the providers are providing high quality services, and you have to get that in writing from them, okay? So the next slide. So there are a couple of things for program planning. There's a very good program planning template developed by Kellogg Foundation, and so I strongly recommend that before you plan, you use this template and you identify some of the problems and issues. You may want to do this as a group exercise involving some of these providers that you want to work with and some of the schools that you want to work with. You can do it individually or as a group exercise. So you identify what are the needs and also the assets. So the key asset is the availability of providers and the equipment and the support cost for the first year for supplies. And using that one, what can you achieve? What are some of the outputs, outcomes, and impact? And then what are some of the factors that influence all these things? And what are some of the key strategies for approaching schools, approaching providers, approaching getting better consent forms, linkage with providers for ongoing clinical care. All those strategies, you think about it and outline it here. And then of course, you're going to make some assumptions about cost, about, revenue, all those things, you think about it. So this is a very good program planning template to use.
And Dr. Sorry, Dr. Kumar,
go ahead.
one question. As the counties are going through the program planning template, if they already have a school-based Sealant program, could the RFA be used to expand existing programs?
Yes. And if you have old equipment, you can replace that with new equipment. If you want to add some additional equipment to improve the referral, you can apply for that as well. So the next slide is a logic model for a school-based program. This was developed by CDC in collaboration with state health department. So the next slide. Yeah, okay. So this is a logic model developed in collaboration with state health departments. This can be expanded. This can be refined. So I was part of the CDC grant program when we developed this template. So the next one. Okay. So here are some questions you can anticipate. So the first one is no need for a program in my school. So this can happen. You will get this response from schools, also from some of the practitioners in the community. I'm taking care of all my patients. There is no need to set up this preventive program because this will give parents a false sense of security. So this is where you should, convince the community practitioners that by having this program, you are actually making referral and increasing the number of children seeking regular care in their office. So your role is to facilitate this one-time clinical sealants, with clinical service, which is long-lasting sealant, but not for primary care. Okay, so this is for ongoing care, they'll be referred to community practitioners. And the other one is sealants don't work. So you have a lot of papers to support why sealants work. So this is based on many practitioners' experience in their office. They have seen other providers apply sealants, and they say, unless I provide it, it won't work. It has to be. It is very meticulous. So that's the reason why many practitioners have this perception, which is not supported by data from clinical trials, is because when they're asking dental hygienists apply sealants or dental assistants apply sealants in their office, is because they're doing it alone, not as a four-handed dentistry. So this is a very technique-sensitive procedure and requires meticulous attention to meticulous details. And you have to use your data to show them that sealants work. And sealants should not be placed without x-rays. So we addressed that by an expert panel, and that paper should be available to you. I see cavities underneath sealants. So Susan Griffiths undertook extensive research and answered this question that it is safe to see sealants. Actually, many researchers strongly believe that sealant should be applied, and you can make it very cost effective if and show cost savings if you apply sealants on incipient lesions. And then, so the other question that often comes up is, it's easy to do fluoride and sealants and prophase. It's really difficult to do fillings on these young children when they end up getting only those requiring fillings. And so you have to anticipate these questions. So generally what I recommend is, if you decide to go it, you should inform the community practitioners, and this is what we are planning. And if they have any questions, that they should approach them and ask their opinion how it can be addressed, either through consent. For example, if there are many children may be already going to a dental office and receiving care, so those are established patients. So you can easily address that in the consent form. If you have a family dentist, you should seek dental care and not use these school services. This is, and you can explain to everyone that this is for those who do not have a family dentist or a dental hygienist. So those kinds of questions you are anticipating. Okay, and lastly, about resources. So there is a nice publication by the National Maternal and Child Oral Health Resource Center. And next slide is the details. So all the forums and guides, all those things are available. So I point to two manuals. One is the school-based dental sealant program. The other one is Seal America. And I want you to look at those resources before considering a sealant program. Okay. And okay. And this one, we want you to innovate. So don't be afraid to fail. And you have to use this as an opportunity to learn. So this slide shows, first attempt in learning is to look at failures and why things didn't work out, why the consent forms, why the sealants, why the consent rate is so low, why children are not giving you insurance information, why you're saving only 5 children. All those things you can address through a quality improvement program. And the next steps, so start planning and think about it, whether you want to use, what approach you want to use, whether it is a sealant program or a school-linked program or a combination of both. So start thinking about it and look for our announcement regarding this grant opportunity. So I have a few more minutes. I can take questions.
Great, thank you, Dr. Kumar. We do have some questions in the chat box.
Okay.
So it looks like there's a few different models that people are using. Some have to do with billing and some of the details around that, which I think you had said would be in a different webinar. And
yes.
Another one was through a school-based sealant program, and they're non-traditional partners that they're working with.
Mm-hmm.
Yeah. If there's any more specific questions that people have, we're getting a lot of thank yous.
I see. So I must have done a very good job then. So if they have more specific questions, you have the dental director's box, email it to me.
Okay. Great. Yeah, everyone's just.
Do you have any more polls?
We did have some polls. We can go back and see if they work. Let's go through. We had a poll on dental professionals in the community.
Uh-huh.
I'm going to go ahead and launch the poll. And for those on the phone, the poll is, do you have a dental professional in your community that you can consult with for technical issues related to the establishment of a school-based linked program? And the poll hasn't started yet. It looks like it's still thinking about it.
Say it again. I didn't get the question.
Do you have a dental professional in your community that you can consult with for technical issues related to the establishment of a school-based linked program?
So that's why you are there, Katie.
Thank you.
They should direct that question to Dr. Silverstein and his team.
Yeah, please do. I'm going to end it and see if I can restart it. Yeah, everyone's saying excellent, very helpful. Thank you. Thank you, Dr. Kumars. RDHCPs, we were having difficulty with sustainability in the first year with billing. So Dr. Kumar, with all this applause, and this is really great timing for everyone, especially with what's happening, there's more time to plan for programs for later this year or next year when kids are back. When do you think we can do a school linked webinar?
Oh, I can do it in another 2 weeks. But, you know, we have a webinar coming up on April 6th. That's the AACDP, maybe after that. Or they can tell me if they, you know, if they are so eager to hear, maybe we can put together another webinar sometime very soon, in a couple of weeks.
Great. And do you think on the school linked webinar, could we go over more billing questions and more of the details with workforce?
Yeah. So they can, why don't you gather all those questions beforehand so we can come up with an FAQ.
Right. And then could we could send that out to everyone?
Yeah.
Wonderful. And then I think we are at time, but did you want to say anything about the upcoming AACDP that we're doing on Monday, April 6th?
Are you asking me?
Yes, just before we get off the call.
Oh, as I said, we will be sending out an announcement soon about the upcoming AACDP webinar. So we're going to divide that one-day meeting into 5 webinars, and we'll move to a virtual platform very similar to the one we had today. So you'll be able to get the slides beforehand. You will be able to interact with speakers. So we'll make it as interactive as possible. And also, once the virtual meeting is completed, so we'll have a write-up from every speaker. So you will have some written materials to go with the presentation.
That sounds great. So more information coming. And if you can see my screen, I have the California Oral Health Technical Assistance Center, our webpage up. On the home page is information about today's Lunch and Learn that we just had, as well as a link to the slides. And the recording is going to go on the home page. There's also information on COVID-19. And we are going to be looking to put a lot of webinars on here with everyone working remotely. So there's a news and events section. If you go to events, you can see updates on webinars. And there'll be more information on the AACDP coming up. Great. And with that, can we go ahead and close today?
Yes. Thank you very much.
Great. Thank you,
Katie.
everyone. Great. Thank you, everyone. Stay safe, stay healthy, and thank you for joining us for our first Lunch and Learn. And we will be sending out an email afterwards. So thank you.
Okay. Katie, can you stay on the line?
Yes, I can. I'm going to stop recording, though.
Okay. Stop recording.